All right, so you're here because you really want to get a handle on some pretty complex stuff fast. And honestly, that's what we aim to do, right?
Absolutely.
We're going to be diving deep into the approach medical professionals take when they are faced with acute poisoning cases.
It can be a really fascinating area.
Oh, for sure, for sure. So think of this as your personal, cheat sheet or shortcut to really understanding what's going on in those crucial moments. And we're pulling all of this from this really amazing session summary from some real medical experts.
Yeah, we had some fantastic contributors to the original session, real thought leaders in the field.
Yeah, and we're going to try to break down their thought process, like how they approach someone who might have been poisoned. I mean, it can seem overwhelming, but when you listen to them, you start to realize there are definite patterns and a really systematic way that they go about it.
Absolutely. There's a method to the madness, for sure.
Totally. Okay, so let's jump right in. When we say acute poisoning, what exactly are we talking about?
So, acute poisoning is essentially when someone's exposed to a toxic substance, and that exposure causes harm to their body. It could be unintentional, it could be deliberate, but the key is that it's a sudden, acute event.
Okay, so something that happens quickly, not a gradual thing.
Exactly. We're not talking about long-term exposure here.
Gotcha. And then there's this word toxidrome that pops up all the time. I got to admit, it sounds a bit like something out of a sci-fi movie. What's the real deal with that?
Well, you can actually think of a toxidrome as like a clinical fingerprint. It's a set of signs and symptoms that, when you see them together, they really strongly suggest a particular type of toxin.
It's just like a pattern recognition thing.
Exactly. It helps narrow down the possibilities and guide treatment.
That makes sense. So in the expert session, you guys talked about a whole bunch of different toxins, right? Can you give us a rundown of some of the usual suspects?
Oh, yeah. We covered a wide range. We talked about organophosphates,
Yeah.
which are found in a lot of insecticides and pesticides. And, of course, snake venoms. Those always come up. Then there are chemical agents like bleach, things you might have around the house, petroleum products, kerosene.
Right.
And the dangers of inhaling things like carbon monoxide and cyanide.
Yeah, you don't want to mess with those.
No, not at all.
Yeah.
We also delved into prescription drugs, things like calcium channel blockers, opioids, beta blockers, digitalis, SSRIs.
Wow, so it's not just like hardcore chemicals, it can be everyday medications too.
Absolutely, and that's a really important point for people to realize. And of course, we can't forget about toxic alcohols like ethanol and methanol.
Right. So it's a pretty diverse range of substances that we're talking about here. It kind of makes you realize how many potential dangers are lurking out there.
Yeah, it really highlights how important awareness and prevention are.
Totally. Now let's shift gears a bit and talk about who tends to be affected by acute poisoning and where this is happening geographically, the epidemiology of it all.
Sure. So globally, one of the key takeaways from the session was that most poisonings are actually intentional.
Really? So more deliberate than accidental?
Yeah, it was a bit surprising,
Right.
but that's what the data shows. And these intentional poisonings, unfortunately, account for a pretty significant number of deaths worldwide.
That's really sobering.
It is. And another interesting global trend is that females are more often affected than males.
That's intriguing. Now, I know that the summary also mentioned Uganda specifically. What's the situation like there?
Uganda's a bit of a different story. There, organophosphate poisoning is the most common type, likely due to widespread agricultural use. And in contrast to the global trend, in Uganda, it's males and children under 5 who are more frequently involved.
So a completely different demographic. It really makes you think about how the context and the availability of different substances can totally change the patterns, right?
Absolutely. It underscores how important it is to understand those local factors.
For sure. Now, the summary also touched on some of the risk factors, like what makes someone more vulnerable to acute poisoning. Can you talk about that a bit?
Yeah, there are a few key things that can increase the risk. One is psychological distress. If someone's going through a tough time, a really stressful period, that can put them at higher risk.
So mental health plays a role.
Absolutely. And then there's easy access to toxins, which is a huge concern, especially for young kids.
Right. They're curious. They get into everything.
Exactly. And they might not understand the dangers. In agricultural areas, improper handling and spraying of pesticides without the right protective gear is a big issue, leading to unintentional exposures.
Yeah, that makes sense.
And sadly, underlying mental health conditions can also increase the risk of both accidental and intentional poisonings.
So it's a complex mix of factors.
It really is. There's often no single cause.
Okay, so we've got a good sense now of what acute poisoning is, the types of toxins involved, who's at risk, and some of the reasons why this happens. So for this deep dive, what's our main goal here? What do we want you, the listener, to walk away understanding?
Our main mission is to break down the essential information on how doctors and other medical professionals approach and assess someone who's been acutely poisoned. We want to focus on the practical stuff, the actionable insights, and those really memorable patterns that can help make sense of a really complex clinical situation.
Okay, so it's all about equipping our listeners with the knowledge they need to understand how the pros think and act in these critical situations.
Precisely. We want to give them that insider's perspective.
Love it. So let's dive into those memorable patterns, those clinical fingerprints we talked about, the toxidromes. The summary really breaks down a few key ones. Let's start with anticholinergic. I gotta say, it sounds kind of like something out of a Gothic novel.
It does have a bit of a dramatic flair, doesn't it? The anticholinergic toxidrome basically happens when substances block acetylcholine in the body.
Yeah.
Acetylcholine is like this super important chemical messenger.
Right, it helps our nerves communicate.
Exactly. And when it's blocked, all sorts of things go haywire.
So what are some of the key signs to look for?
Well, there's mydriasis, which means the pupils get really dilated, like huge.
Okay, so big pupils. What else?
You often see tachycardia, a really rapid heartbeat,
Heart's racing.
and the skin gets flushed, kind of reddish,
Mm-hmm.
and the skin and mucous membranes become super dry.
Dry as a bone, I've heard that saying.
Exactly. It's very characteristic. Then there's urinary retention, trouble peeing, and hyperthermia, a really high body temperature.
So they're basically overheating.
Yeah, and on top of all that, they can get delirious, confused, and agitated.
Wow, that's a whole lot going on.
It is, but thankfully there's a super memorable mnemonic that helps you remember all those key features. Blind as a bat, red as a beet, mad as a hatter, dry as a bone, hot as a hair.
Oh yeah, that's one you don't forget easily.
It's a classic for a reason. It really sticks with you.
So what kind of substances cause this anticholinergic chaos?
You can think about things like certain antihistamines, those over-the-counter allergy meds,
Okay,
or the drug atropine, which is sometimes used in medical procedures.
gotcha. Now let's flip the script and talk about the opposite, the cholinergic toxidrome, where there's too much acetylcholine instead of not enough.
Right, so instead of blocking it, now we're talking about substances that overstimulate those acetylcholine receptors.
And I know this one has its own catchy acronym, DMBLs.
You got it. DMBL stands for diarrhea, urination, meiosis.
Which is the opposite of mydriasis, right? So constricted pupils.
Exactly. And then muscle weakness, bronchospasm, meaning the airways tighten up.
Making it hard to breathe.
Exactly. And bronchorrhea, where there's excessive mucus production in the lungs.
So breathing's a real issue here.
Absolutely. Then we have bradycardia, a slow heart rate, which is the opposite of what we saw with anticholinergics.
Right, heart slowing down instead of racing.
And then emesis, or vomiting, lacrimation, meaning excessive tearing, and finally salivation and sweating. So you see a lot of fluid coming out.
Yeah, it's like everything's going into overdrive.
And this cholinergic toxidrome is really strongly associated with organophosphates and carbamates.
Which are those common insecticides we talked about earlier?
Right. And it's really fascinating how messing with just one neurotransmitter, acetylcholine, can cause such drastically different effects depending on whether it's blocked or overstimulated. It really highlights how delicate the balance is within our nervous system.
Totally. It's like a finely tuned machine that can easily go off the rails. Now let's talk about opioids. I mean, that's another major category we hear a lot about these days.
Yeah, unfortunately, opioid overdose is a huge problem. And the opioid toxidrome usually presents with a pretty classic triad of findings.
Okay, what are those three key signs?
First, you'll see meiosis, those pinpoint pupils.
Right, the opposite of the dilated pupils in anticholinergic toxidrome.
Exactly. Then there's respiratory depression, meaning the breathing slows down significantly, which is obviously a huge concern.
Yeah, that's life-threatening.
Absolutely.
Yeah.
And finally, there's altered mental status, which can range from drowsiness and lethargy all the way to a full-blown coma.
So not very responsive.
Right. And sometimes, if you listen to the abdomen with a stethoscope, you might hear decreased bowel sounds, too.
Interesting. So a pretty set of findings there. Moving on, what about sympathomimetics? Those are things like cocaine and meth, right? What's the clinical picture with those?
Yeah, with sympathomimetics, think of the sympathetic nervous system, your fight or flight response getting kicked into overdrive.
So everything speeds up?
basically.
Yeah.
You see mydriasis again, those dilated pupils,
Okay.
tachycardia, the rapid heart rate, hypertension, meaning high blood pressure, and diaphoresis, excessive sweating. It's like the body's on high alert, ready for action.
Sounds intense. All right, and the last specific toxidrome mentioned in the summary is sedative hypnotic. What are we looking for there?
Sedative hypnotics, like benzodiazepines, alcohol, GHB, they tend to cause a slowing down of bodily functions.
So the opposite of the fight or flight response.
Exactly. You might see lethargy, coma, and even hypothermia, meaning a low body temperature.
Okay, so they're basically shutting down.
In a way, yes. But it's important to remember that respiratory depression, that slowed breathing, is much more common and can be much more severe when these substances are mixed, like alcohol and benzos together.
So mixing those drugs can be particularly dangerous.
Absolutely. It could really amplify the respiratory effects.
Gotcha. So recognizing these toxidromes seems like a super important first step. But what if you don't know the specific toxin involved? The summary emphasized the importance of the history and physical exam. Let's start with the history. What kind of information are medical professionals trying to gather?
Getting a detailed history is absolutely crucial. You need to find out exactly what substance was taken, if possible. And if there are any other medications involved, either prescription or over-the-counter, that could interact.
So like a full medication list.
Exactly. And finding empty pill bottles or containers can be a huge help.
Right, those can be valuable clues.
Absolutely. And then you want to ask about any history of seizures or loss of consciousness.
Okay, so any past neurological events.
Right. And don't forget about the patient's medical history, especially any liver, kidney, or heart problems, because those can really affect how the body handles toxins.
Makes sense.
And here's the thing. Even seemingly small or irrelevant details can turn out to be really important pieces of the puzzle.
It's like being a medical detective piecing together all these clues.
Exactly. You got to be thorough and observant.
And then comes the physical exam. How can that help when you're dealing with an unknown ingestion?
The physical exam can provide so many valuable clues. As the summary highlights, changes in vital signs and specific findings can point you towards certain classes of toxins.
Okay, so let's break it down, starting with the heart rate.
Right. So if you find bradycardia, a slow heart rate, it might suggest things like beta blockers, calcium channel blockers, digoxin, opiates, organophosphates, or even some sedative hypnotics.
Okay, so quite a few possibilities there.
Yeah. But if it's tachycardia, a fast heart rate, that could point to adrenergic and anticholinergic agents, as well as digoxin and theophylline.
So a rapid heart rate could indicate a few different things.
It could. And it's important to remember that in a poisoned patient, a fast heart rate could also just be a general stress response, not necessarily specific to the toxin itself.
Right, so you have to consider the whole picture. What about breathing patterns, respirations?
So if you see bradypnea, meaning slow breathing, it could be a sign of respiratory depressants, those drugs that slow down breathing, or even neuromuscular blockers, which paralyze the muscles involved in breathing.
Gotcha.
On the other hand, tachypnea, rapid breathing, could indicate a few different things. It might be caused by substances that lead to metabolic acidosis, a buildup of acid in the blood. Examples are methanol or late-stage salicylate poisoning. It could also be a sign of early salicylate toxicity, inhaling irritant gases, or conditions that cause toxic hypoxia, where the body's tissues aren't getting enough oxygen, like in carbon monoxide poisoning.
Right, that makes sense. Temperature is another key vital sign. What can that tell us?
A low body temperature, hypothermia, can be associated with carbon monoxide poisoning, ethanol, opiates, and it's often seen with hypoglycemia, low blood sugar.
So you always got to check that blood sugar.
Absolutely. Now, hyperthermia, a high body temperature, might be due to a few things. Increased muscle activity during seizures, impaired temperature regulation, like we see with anticholinergics, hypermetabolic states like salicylate poisoning, or even a rare but serious condition called neuroleptic malignant syndrome.
Wow, so many possibilities. And blood pressure is also a key indicator, right?
Absolutely. Low blood pressure, hypotension can happen in significant poisoning cases, as well as situations that cause dehydration, like severe diarrhea or sweating. And if it's coupled with a slow heart rate, that might point to beta blockers, calcium channel blockers, or digoxin.
Okay, so those go together sometimes. What about high blood pressure?
High blood pressure hypertension can be seen with anticholinergics, scorpion venom, and sympathomimetics.
Gotcha. Now, pupil size seems like a really telling sign, especially given those toxidromes we've discussed.
It really is. Pinpoint pupils or meiosis are characteristic of nicotine, opiates, organophosphates, carbamates, and even certain types of brain hemorrhages.
Okay.
But dilated pupils, mydriasis, can be seen with sympathomimetics, hallucinogens, anticholinergics, and even during withdrawal from opiates. That's why we have the acronym SHA-double to help us remember. Sympathomimetics, hallucinogens, anticholinergics, withdrawal from opiates.
Right, that's a good one.
And here's a crucial point. Only anticholinergics typically cause pupils that are not only dilated, but also completely unreactive to light.
Oh, so that's a key distinction.
It is, and if you see unequal pupil sizes, that might suggest something else is going on, like a neurological issue, rather than just a simple poisoning.
Gotcha. Finally, the neurological exam. What are the pros looking for there?
The neurological exam can reveal a lot. You might see things like toxic paralytic syndromes, which can be caused by botulism, strokes that can happen in the context of a sympathomimetic overdose, the delayed nerve damage sometimes seen with organophosphates, and various venoms.
So some pretty serious stuff.
Yeah, definitely. But you might also see tremors, which could suggest anticholinergics, chronic alcohol use, or sympathomimetics.
Okay, so tremors aren't always a specific sign. Now, you mentioned hypoglycemia earlier, low blood sugar. It sounds like that's something medical professionals are always on the lookout for in poisoning cases.
Yeah, hypoglycemia is a really common complication of many different toxic ingestions, and it can make the patient's condition much worse if it's not caught and treated quickly.
So it's always on the radar.
Always, you got to be vigilant.
Okay, so history and physical exam are super important. What about actual diagnostic tests? What role do those play in figuring out what's going on?
This is where it gets interesting. The summary actually emphasizes that broad diagnostic testing, like ordering a whole bunch of tests, has a somewhat limited role, especially in settings where resources might be scarce.
That's not what I expected.
Yeah, a lot of people think it's all about fancy tests, but often the initial management is more about recognizing patterns, stabilizing the patient, and providing supportive care.
So it's more about clinical judgment than just relying on labs.
To a large extent, yes. Now, there are some routine tests that are often ordered, like checking the blood sugar level to rule out hypoglycemia, and a urine pregnancy test for any female patient of childbearing age.
Makes sense.
And then there are certain situations where specific tests become more valuable.
Okay, like what?
So an ECG, an electrocardiogram, can be really helpful in certain overdoses. For example, with tricyclic antidepressants, or TCAs, you might see a widening of the QRS complex on the ECG. Basically, the electrical signals in the heart get messed up, and that shows up as a wider QRS. A few different drugs can cause this, but it's a particularly important sign to look for in TCA overdoses. The summary even lists some other drugs that can do this, like certain antimalarials, carbamazepine, dextropropoxyphene, local anesthetics, propranolol, quinine, type IA, and IICEC antiarrhythmics. It's good to be aware of those.
Wow, that's a lot of drugs.
It is. And ECGs can also be useful in cases of beta blocker overdoses. X-rays can also be helpful in specific situations, like if you suspect someone swallowed iron tablets, because the iron can sometimes show up on the X-ray. Or if you're dealing with body packers, those people who swallow packages of drugs to smuggle them.
Oh, wow, I've heard of that.
Yeah, it's a dangerous practice. Now, what about more general lab tests? Those can be helpful too, right?
Yeah, what about the...
Definitely. Measuring electrolytes, including bicarbonate levels and calculating something called the anion gap, which can point to certain metabolic disturbances, as well as checking kidney and liver function, all of those can provide valuable information to help guide diagnosis and treatment.
So those are more for overall assessment and monitoring.
Exactly. They help you see how the body is being affected by the poisoning.
Okay, so we've got those basic tests and some more specific ones. Now, what about those urine and serum toxicology screens that you always see on TV? Are those as helpful in real life in acute poisoning cases?
This is a really important point. The summary actually says that those broad urine and serum toxicology screens are often not very practical or useful in the initial management of a poisoned patient. They can take a while to get results, and even when you get them, they might not actually change what you do immediately.
So they're not always the magic bullet that TV makes them out to be.
Exactly. The immediate focus is usually on supportive care and stabilizing the patient.
Makes sense. What about arterial blood gases and serum osmolality? Are those helpful?
If they're readily available, arterial blood gases can be really useful because they give you a good picture of the patient's oxygenation, ventilation, and acid-base balance. Serum osmolality, which basically measures the concentration of stuff dissolved in the blood, can be helpful in certain toxic alcohol poisonings.
Okay, so those are more specialized tests.
They are, but they can provide valuable information in certain situations.
So diagnostics have a role, but it's more targeted than most people might think. Which brings us to treatment. The summary really stresses that management is primarily supportive. What does that initial supportive care involve?
The absolute first priority is ensuring the safety of both the patient and the medical staff. That means using personal protective equipment, or PPE, and doing proper decontamination to remove any remaining toxin from the patient's skin or clothing.
Right, so protecting everyone involved.
Exactly. And the immediate goal is to stabilize the patient, and that follows the classic ABCDE approach.
Airway, breathing, circulation, disability, exposure. I remember that from my first aid course.
Yep, that's the one. It's a systematic way to assess and address life-threatening issues.
So how does that apply to poisoning cases?
Well, starting with airway, you got to make sure the airway is clear. Is there any obstruction, maybe from secretions or a decreased level of consciousness? If so, you got to clear it, protect the airway, which might involve inserting a breathing tube, and provide mechanical ventilation if the patient's not breathing adequately on their own. It's also crucial to immediately reverse any reversible causes of airway compromise.
Like what?
Like an opioid overdose, you'd give naloxone, the antidote, or hypoglycemia, you'd give dextrose to raise the blood sugar.
Okay, so those are quick fixes.
They can be life-saving, yeah. Next is breathing. This can be seriously affected in cases like opioid or sedative overdoses. You want to make sure the patient's getting enough oxygen, address any signs of respiratory distress, and potentially intubate them to support their breathing.
So breathing is a big concern.
Huge. And in the specific case of a cholinergic toxidrome, you have to be careful with a certain paralytic medication called succinylmethonium. And for organophosphate poisoning, managing those excessive secretions and giving atropine are important steps.
Right, atropine was mentioned earlier for that. Okay, what about circulation?
Circulation is all about supporting the cardiovascular system. The first step is usually giving intravenous fluids if the patient's blood pressure is low. If fluids alone aren't enough, you might need vasopressors, those medications that help raise blood pressure. And you always want to do an ECG to look for any heart block, a prolonged QTC interval, which can increase the risk of dangerous heart rhythms or other arrhythmias.
So you're monitoring the heart closely.
Absolutely.
Yeah.
And if you see that widened QRS complex on the ECG, like we talked about with TCA overdoses, giving intravenous sodium bicarbonate can be really helpful. Now, for patients with low blood pressure and a slow heart rate from beta blocker or calcium channel blocker overdose, there are specific treatments like high-dose insulin, along with a dextrose infusion, glucagon, and vasopressors. And in really severe cases that don't respond to those, you might even consider things like intralipid infusion, which can bind to some fat-soluble toxins, or even ECMO, extracorporeal membrane oxygenation, which is a form of life support where blood is oxygenated outside the body. But those are more advanced and not always available.
Wow, so those are last resort options.
They are, but it's good to know they exist.
Definitely. All right, what about the ease exposure?
Exposure involves decontamination, removing those contaminated clothes and washing the skin to prevent further absorption. It also includes treating any other injuries the patient might have and managing their temperature. That means active cooling for hyperthermia and passive or active rewarming for hypothermia.
So you're addressing everything related to the actual exposure to the toxin.
Exactly. You're trying to minimize any further harm.
Makes sense. Now, we talked about supportive care being the foundation, but what about specific antidotes? Are there any magic bullets that can reverse the effects of certain toxins?
Thankfully, there are antidotes for some poisonings, and when they exist and are available, they can be absolute lifesavers. For organophosphate poisoning, we have atropine and pralidoxime. For opioid overdose, it's naloxone, which is becoming more widely available. For acetaminophen overdose, there's N-acetylcysteine. Beta blocker toxicity can sometimes be reversed with glucagon or high-dose insulin. Calcium is the antidote for calcium channel blocker overdose. Physostigmine can be used in certain anticholinergic poisonings. For warfarin, the blood thinner, it's vitamin K. And for poisonous bites, we have antivenoms, which are crucial.
Wow, that's a lot of antidotes.
It is, and knowing which one to use for which poisoning is super important. Remember we talked about sodium bicarbonate being helpful for TCA overdoses.
Right.
And for low blood sugar caused by insulin or sulfonylurea medications, we have dextrose and glucagon. And finally, for those toxic alcohols like methanol and ethylene glycol, we can use ethanol or foamaceular.
So it's like a whole arsenal of specific weapons against these toxins.
Exactly. But it's crucial to use the right weapon for the right target.
Totally. Now, what about those enhanced elimination techniques we sometimes hear about, like pumping the stomach or using activated charcoal?
The role of those has evolved over time. Gastric lavage, which is stomach pumping, is generally not recommended anymore, except in very rare situations involving extremely toxic substances like colchicine. And even then, it should only be done after talking to a toxicology expert because of the risk of aspiration, which is getting stomach contents into the lungs.
So it's not as routine as it used to be.
Not at all. What about activated charcoal? I know that one's still pretty commonly used.
Yeah, what about activated charcoal?
Activated charcoal can be helpful if it's given within 1 to 2 hours of the ingestion, and only if the patient's airway is protected. Ideally, they've been intubated to prevent aspiration.
Okay, so airway protection is key.
Absolutely. Activated charcoal works by binding to many toxins in the digestive tract so they don't get absorbed into the body. But it's not effective for everything. It doesn't work for metals, alcohols, or corrosive materials.
So it has its limitations.
It does. And in some cases, like with overdoses of carbamazepine, phenobarbital, salicylates, and amenophyline, you might give multiple doses of activated charcoal.
Okay, so sometimes you got to repeat it.
Sometimes, yeah.
When is whole bowel irrigation used?
Whole bowel irrigation, where you essentially flush out the entire gastrointestinal system, is helpful in situations like iron tablet ingestions or when you're dealing with those drug packers who have swallowed packages of drugs.
Right, so it's for those specific situations.
Exactly. It's not a routine thing. The summary also mentioned hemodialysis, right?
Yeah, it did. What's the deal with that?
Hemodialysis is a way of filtering the blood using a machine, and it can be considered for certain toxins that are easily removed from the bloodstream. The summary specifically mentions methanol, ethylene glycol, and salicylates as examples, and there are general criteria for when hemodialysis might be needed in a poisoning case, like severe acid-base imbalances or kidney failure caused by the toxin.
So it's reserved for those really severe cases.
Yeah, it's a more intensive intervention. And finally, there's urine alkalinization.
Oh, yeah. What's that all about?
Urine alkalinization basically involves making the urine more alkaline, less acidic. And that can help the body get rid of certain acidic toxins like salicylate and phenobarbital because it makes them more water-soluble, so they're easier for the kidneys to excrete.
So you're manipulating the pH of the urine.
Exactly. It's another way to enhance elimination.
So we've got all these different techniques, but it sounds like supportive care and those specific antidotes are really the mainstays of treatment.
They are. Addressing those ABCs and using antidotes when available are really the most effective ways to manage these cases.
What are some of the potential complications that can happen with acute poisoning?
There are quite a few. One is aspiration pneumonia, which can happen if someone vomits and inhales some of that vomit. Respiratory failure from depressed breathing is another big concern. Then you have cardiac arrhythmias, those dangerous heart rhythms, and in severe cases, you can even see multi-organ dysfunction, where multiple organ systems start to fail.
So things can get pretty serious pretty quickly.
They can, which is why prompt recognition and treatment are so crucial.
For sure. Now, how do medical professionals decide where a poisoned patient should go after they've been stabilized? What are the considerations for disposition?
Well, if the patient is unstable, they'll likely need to be admitted to the intensive care unit, or ICU, for close monitoring and more advanced support.
Okay.
But if their case is less severe, they might be admitted to a general medical ward. And for any intentional overdoses, it's really important to get a mental health evaluation.
Right, to address the underlying issues.
Absolutely. And the summary stresses that if there's any suspicion of a crime or a public health risk, the poisoning should be reported to the appropriate authorities.
Okay, so that's a legal and ethical consideration.
It is. It's about protecting the patient and the community.
Makes sense. Now, the summary ends with some special notes. Are there any particularly important points you want to highlight?
Yeah, a few things. Regarding organophosphate poisoning, they emphasize being really aggressive with atropine, sometimes even doubling the dose every few minutes until the patient's secretions dry up. That's a key point.
Okay, so don't be afraid to push the atropine.
Exactly. And they mentioned activated charcoal again, saying it can be beneficial within the first couple of hours if the airway is protected, although it's not universally indicated.
Right.
And they also point out that being pregnant doesn't fundamentally change the initial treatment approach for poisoning. You still follow the same basic principles.
Okay, so pregnancy is not a contraindication.
Not for those initial steps, no. And finally, they reiterate the importance of staff safety and using PPE to prevent secondary exposure. That's a crucial reminder.
Yeah, you don't want the medical team getting poisoned, too.
Exactly. Safety first, always.
Okay, so just to quickly recap everything we've covered, recognizing those toxidromes, those distinct patterns, is a super powerful first step in assessing a poisoned patient. A detailed history and a focused physical exam provide tons of valuable clues, especially when you don't know the exact substance involved. And broad toxicology screens, while they might seem like the go-to on TV, aren't always the most.